Good morning, everybody. I'm Lisa Ray Thomas with the University of Washington Alcohol and Drug Abuse Institute. Thank you so much for joining us this morning. It's 9 o'clock, and I'd like to be respectful of people's time. May, could you go to the next slide, please? So here's a housekeeping slide. Please stay muted and keep your camera off during our session today, and please use the chat to ask questions and comment. We will be collecting all of the comments and questions in the chat box and responding to them going forward. We also wanted to let you know that this session is being recorded, and you can hide non-video participants to optimize your screen. If you hover over the upper right corner of a participant box, you see the 3-dot icon, click on that, and then select Hide Non-Video Participants. With that, I would like to welcome Chairwoman Charlene Nelson of the Shoalwater Bay Tribe to open up our day in a good way. Thank you so much, Chairwoman Nelson.
Good morning. Sorry, are you all there?
Yes, thank you.
Okay, I'd like to thank the kind person, Ed, who came in and helped me set up this morning. Yay. I'd like to welcome all of you there. You're there for a purpose, and we all sometimes don't know our purpose. And I think it's very important that you think about. We all care for something, and you make a difference to people. This morning when I got out of my car, I decided maybe I better take a walk, mile walk or half-mile walk I did this morning. And I saw in front of me a deer, and I thought, how wonderful. And if you look at our world around us, it is wonderful. You look at the people around us, it's wonderful. We know some people are challenged because of use of things that make them see the world differently. And I dedicate my words to a niece that I love greatly, who went out the door and did not come back. But I know that she, had she stayed, would have been a great leader. And I do whatever I do in her memory. Again, I'd like you all to take a deep breath, because what we say this morning, what we hear this morning is important. And as all meetings I open as a chair or open in other places, I open with a blessing. And I feel that is important as we let everything else go and we listen to what we're listening this morning. Because someday you could make a difference, a big difference in somebody else's life by knowing something, words to say, things to do, or just being there that will help them get up off the floor. I would like now to do the blessing. Almighty God, Creator, Master, I thank you for this day, and I thank you for all the people that I can't see that are listening. Be with us all today and help us to learn something that we didn't know before. Help us, God. Be with us. Help us not to pass anybody by And I hold up in my memory Freddie, George, Manny, and all the others who are not here, but are witnesses. Witnesses to us all. Help us again to laugh, to take that deep breath, not laugh in a mean way, but laugh in a kind way, and listen. I thank again that you have brought these folks together, all the people that I can't see right now, and give us a good morning and a better understanding for people that we want to transform so that we can transform a community, a city, a state, a country, the world. And I say Masi, which is thank you. Amen. And now I know we're close for time, and so it's all yours, Lisa, my friend.
Thank you so much, Chairwoman Nelson. My hands are up to you. Now I'd like to introduce Brad Feingood from Seattle King County Public Health, who's going to provide a welcome and an introduction to our morning together. Brad?
Thank you so much. This is Brad Feingood from Public Health, Seattle King County. Thank you, everybody, on behalf of all of us who have worked so hard to put this conference together. Thank you, Chairperson Nelson, for the amazing grounding in this morning. It just resonates with me how we need to be purposeful throughout our day today and purposeful throughout our work because so many people depend upon us. I, like Chairperson Nelson, have been touched and impacted by so many loved ones who have succumbed to overdose or struggle on a daily basis. And we have the opportunity here today to continue our work and to be grounded into the work of what we needed to do. This two-day summit is a unique opportunity to bring diverse people together to better understand the needs and strengths of people in our community who use drugs to improve health, equity, and justice for them. The intent of this two-day summit is to kick off what we will continue to gather and strengthen our networks and transforms our systems of care. Today is day 2, and we have almost 480 people registered today. I've been watching the participant list as it's grown to over 200 already a couple minutes in. That on top of the approximate 330 people who are in attendance of day 1 puts us at about 600 people who have registered to participate in one or both of the days. Day 1, to recap a little bit, included an opening and blessing from an indigenous leader, a welcoming, a pre-summit survey that helped guide our planning. There was narratives from people with lived experience, videos, and personal narratives, discussion about the process, and findings from the from other data we have from the syringe exchange survey. All in all, there were 10 breakout sessions. The breakout sessions went from 4 people to 60 people, regardless of size. People found the discussions helpful. We'll be able to summarize the report in the near future in the next couple of weeks as we are able to synthesize all the information that came out of today. There's been some themes across whether it's the pre-summit survey or the conversations about housing, homeless supports, our critical needs, meeting people where they're at, and treating other conditions like stimulant use disorder. Today, we're going to hear narratives from people with lived experience, have a discussion with a panel representing a continuum of housing and homeless supports for services for people who use drugs and people in recovery. We're going to take a short break, and then we'll be able to reconvene again in regional breakouts, and hopefully everybody can jump back on their regional breakout after the break. If we can put up my slide. To me, the war on drugs is a big part of why we're here. Over the past 20 years, I have, between lived experience, family experience, and work experience, bared witness to the war on drugs and the cost that it has played on the incarceration of communities of color. There is no better time outside of today to be able to raise this issue and to remember all of the work that we do needs to be rooted in equity and social justice, and to remember that the communities that have been impacted by the war on drugs have been it's been disproportionately impacted by communities of color. According to Bureau of Justice Statistics, about 58% of state prisoners and 63% of sentenced jail inmates in between 2007 and 2009 met criteria for some type of substance use disorder. The United States has less than 5% of the world's population, and we consume 2/3 of the world's illegal drugs. And we incarcerate almost a quarter of the world's population. So of all the world's population of people incarcerated, 25% of them are in the United States. More than 8 out of 10 who have substance use issues. Next slide, please. In 2018, the imprisonment rate of Black residents was the lowest since 1989. So over the past 20 years, we've been making a little progress. Next. But even despite that progress, people of color are disproportionately impacted by incarceration due to drugs. The imprisonment rate of Black females was 1.8 times higher than that of white females. And for Black males, that number was 5.8 times as high as it was for white males. Next, please. Especially young males. Black males aged 18 to 19 were 12.7 times as likely to be in prison as white males of the same age. So as we go through our awakening, if you will, around social justice, keeping in mind what people deal with on a daily basis and understanding the ways that communities of color have been impacted by this war on drugs. You can go to the next slide. It takes me to a time when 15 years ago, I was working in prisons, and I walked into a room to run a substance abuse group in a prison in Michigan. And as I walked in and I looked around, I realized that I was the only white person in the room. The rest of the room was filled with men of color, some of them who have been in prison for 10 to 15 years. And I just thought how amazing and how awful it was that when I was walking out of there today, and I was going to go home to my newly born son, while all these men of color were stuck behind bars and taken out of their communities. Hispanic males age 18 to 19 were also 3 times more likely than white males of the same age to be in prison. And all those statistics, were from 2018. Next slide. You can keep going. So with people being incarcerated to the war on drugs, it's caused generations of societal trauma. Male and female figures have been taken away from their families due to often the same crimes that people that are not of color. The white community has not been taken out of the community. Among white children in 1980, only 0.4 to 1% had an incarcerated parent. In 2008, almost 30 years later, that number increased significantly, almost doubled to 1.75%. Rates of parental incarceration were roughly double among Latino children with 3.5%. Among African American children, about 11% had a parent incarcerated in 2008. More than 1 out of every 10 African American child had a parent that was incarcerated. Next slide. 1 in every 28 children in the United States, more than 3%, now has a parent in jail or prison. 25 years ago, that number was only 1 out of 125. For Black children, incarceration is especially common. More than 1 in 9 Black children, as I just said, had a parent in prison or jail. a rate that is more than quadrupled in the past 25 years. So as we go throughout our day, I have chosen to be purposeful about acknowledging the fact of the war on drugs and the disproportionate impact that it has had on people of color. I challenge you to be purposeful today, throughout our day, thinking about how you can make a difference in the lives of people who use drugs for the better, and not continue to perpetuate systems that have disproportionately impacted people who use drugs and people of color. And with that, I will throw it back to you, Lisa, or over to Caleb. Thank you.
Thank you so much, Brad.
Great. Thank you very much, Brad, and thank you, Chairwoman Nelson, as well, for encouraging us to listen today and help people get up off the floor. It's what we're about, and I appreciate the sentiments very much. I'm really honored to introduce our planning committee, an amazing group of folks. We've been meeting twice a month since February, which feels incredibly long ago. So I'll introduce myself. My name is Caleb Banter-Green. I'm a researcher here at the Alcohol and Drug Abuse Institute at the University of Washington. I'm also with the School of Public Health. And I'm very happy to be joined with a huge number of folks who are behind the scenes throughout this process, and also today, Meg Bruner here with our Library and Dissemination Group. Our director here in that unit is doing amazing work for pulling this all together today and making things run, kind of our extraordinary disc jockey, which I appreciate so much. Sarah Deutsch with the Hepatitis Education Project has had multiple roles over these last few months, and we really appreciate her important contributions. Lisa Ray Thomas, who started us off today, is here with the Alcohol and Drug Abuse Institute and has been very important, instrumental in really getting this work going, helping us think about the structure, helping us think about our purpose and our process and how we can all make that real. Nicole Branch has been incredibly important on the technology side, keeping us functional and moving forward, and I really appreciate her contributions. You'll recognize Kayla Moontree if you were here at our session a couple of weeks ago. Kayla Moontree is the Kitsap Public Health District and helps support that syringe service program there. You just heard from the fabulous Brad Feingood, who is a strategic advisor with Public Health Seattle-King County. We've been working for several years together on King County's opioid response and co-chair the treatment work group there. And he's been really instrumental in helping think about this. We've been thinking about how we can help support this type of work for quite a while, well over a year. And I think what you'll hear today, and hopefully what you heard last time, is this is very different than what we often do as a university. We're not just pushing out content about microbiology to microbiologists. We're trying to create a process, a really interdisciplinary, community-driven process. And so we're trying to support that, not just lead it, but really help facilitate that. And speaking of facilitation, Malika Lamont is really helping drive this process, really help make sure that we are core to being of service to people who use drugs, and she's from multiple different perspectives, and she'll introduce herself later as well. She's with the Olympia Butte Clinic, Public Defenders Association, and Law Enforcement Assisted Division diversion program. Patricia Dean is with the Washington Healthcare Authority, the Division of Behavioral Health and Recovery, which is helping support some of this work through Alcohol and Drug Abuse Institute. Mandy Sladkey is with Public Health Seattle-King County and is working on opioid-related responses there. It's been really important in supporting this work locally. Katie Strozik, who I've been on many meetings with recently, including yesterday, is with Thurston County Public Health and helps support that syringe service program and has great on-the-ground perspective. And Emily Hirio from the Washington State Department of Health helps support our state syringe service programs all around the state and has been really a critical partner in all of this work. So I will leave that in terms of the group. And then what I would like to do is to introduce the live poll next. And just a reminder to folks that if you're not speaking, if you could turn off your audio and video, that would be great. So if you can go ahead and answer this live poll, we'll take about a minute or two. So if you can answer this first question now, please.
Yes, and I'm going to read the question out loud for people who are on their phones. This is Lisa Ray Thomas. Thank you. So the first question is, did you participate on June 22nd, day one of this event? Yes or no? Great. So the response, 75% of people who are with us today participated on June 22nd. And then it's pretty exciting, 25% of you, this is your first time with us. Thank you so much. And before we go to the next question, I want to apologize on behalf of our team for, on June 22nd, for the question that's going to come up next, not allowing people to choose all that apply. We acknowledge that that resulted in people not really being able to reflect who they really are. We didn't really understand who our participants were, and that by doing that, that was stigmatizing. So thank you so much for bringing that to our attention, and thank you for your patience with us as we grow together. So the second question, who is with us today? Please select any, all that apply. So this is multiple choice. And the choices are lived experience, behavioral health primary care provider or administrator, care manager, navigator, peer support, harm reduction program, tribal urban Indian program, criminal legal system, elected official policymaker, first responders, so law enforcement and fire EMS, for example, housing, homeless services, and other. And if you select other, please chat what other is, or type what other is in the chat box. Thank you. And Caleb, I'll let you read the results when the poll's closed.
Wonderful. Thank you very much. So here's what we have. We have 28% of folks said they had lived experience, which is fabulous. It really is really essential to us that this meeting involve people with lived experience. This work cannot be driven by, quote, outside experts. It has to be truly driven by people with lived experience. I'm really excited we have such a large proportion of people who self-identify that way. Most common response, 39% behavioral health, primary care, and or administrators in those types of positions. So a substantial minority there. A third of people identify as a care manager, navigator, or peer support. A quarter of people with harm reduction programs, which, as we talked about last time, is really important. We've had meetings in the state from a prevention perspective and from a treatment perspective for 35 years. This is really one of the first large statewide meetings. It's much more about sort of the public health and harm reduction side of this work around substance use. So I'm excited to see that. Really honored and appreciate people who identify as tribal and urban Indian. 2% of folks joining us identifying that way. About 1 in 5 identify with the criminal legal system. Really important partners to help support this work, and I think are really transformative in the last few years, I think, around criminal justice policy in this country generally and in our state in particular, and I hope this work will help continue to drive that process. Really happy to have our elected officials and policymakers, and really happy they're with us, 2%, and I would encourage people in their communities to also reach out and maybe share the information you learned today with folks in that perspective. We have 1% of people identify as first responders. Really want to make sure that we're involving those folks as well. They have such an important role. They have so many touches with people out in the community, and we want to make those opportunities to engage with people and serve them in the best way we can, and that they're going to be very important partners. Then almost 1 in 5 identify as housing and homeless services, and I am really, really honored to have those folks with us. They're just essential partners. We know that a lot of the work that we do around information gathering and information dissemination around substance use, I hear repeatedly housing providers saying, we need and want more. Please support us in this work. And we absolutely want to do that. You're going to hear more about that in a few minutes. I'm very excited about that. And I'm not going to try to read 30 people's responses to the other, but they are there in the chat box. I appreciate people recognizing that. And they're coming at this from multiple perspectives. So thank you all so much for filling out those polls, and I do hope you'll take good use of those polls and chats today. This is a very challenging way to interact, and I'm very heartened by everybody's efforts. I know it takes more work to sort of actively be involved in the conversation, so thank you for that. So I think we're going to hand it over now, if I have that right, Lisa, to Christina.
Yes, thank you. Welcome so much, welcome Christina Moeller-Shin, who's the program coordinator for the opioid substance use response with Mason County Community Services and Public Health.
Can you hear me okay?
Yes, thank you. Good morning, Christina.
Good morning. Thank you for having me.
Where do you feel accepted and supported? Why? With you guys at the Syringe Exchange. Nowhere else. You're kind. I can tell by your tone of voice, the way you look at me. You truly listen. You take the time to listen. You don't judge me. Help me when I need it. Here, at the Syringe Exchange. That's the truth. I feel safe, not entrapped. At home, with family. Because I know, no matter what, they'll always be there. They can be mad, but they'll never judge.
So the biggest theme I hear, including last session's narrative, is kindness. Kindness shows up through genuine interaction, through body language and the words we choose to use. Genuine interaction leads to trust and embodies a sense of safety that allows participants to want to open up and be honest with the issues they're facing, truly meeting people where they're at today with no expectations that may hinder care. Stigma and judgment show up in many ways: a flinch from the receptionist, a disciplinary warning from a nurse, being excluded from certain medical treatments unless a person meets certain abstinence requirements. We don't want to shame people when they come to us. This has been a huge barrier in the care of people who use drugs. Another theme that presents is family. There's a misconception, which you'll hear about momentarily, that people who use drugs don't have the capacity or ability to care about themselves and others. My experiences have been far from that. People who use drugs have learned to become their own safety net and use their skills and ingenuity to tend to one another without engaging in the traditional medical settings, largely due to past experiences of stigmatized care. We see this through DIY wound care, through learning how to recognize what overdose looks like and distributing Narcan to friends, through practicing harm reduction, like engaging with syringe service programs and using safer injection techniques. One thing I'd really like us to start doing is caring about the whole person and not just their habit, and truly providing comprehensive wraparound care in prevention, treatment, and recovery for people all along the continuum of drug use, from actively using to abstinence. Next section, please.
What does support look like for you? No judgment. Not making me feel like there's something I need to apologize for. Not showing disappointment. Knowing you're getting the highest level of care, regardless of what the care is. Trying to help, not prosecute, by requiring a UA before receiving medical services.
Many of these responses seem to really have a level of shame embedded in them. They tell a story of a community that engages in a system of judgmental and punitive care, where the result is that a lot of major issues go unaddressed and have a higher chance of leading to emergencies or death. What are we as providers and agencies doing and saying that are playing into this role? What can we do to create a culture change in this field that doesn't make people feel like they have to apologize in order to receive quality care? This may involve having to really look within ourselves as providers to address our own stigmas that may be showing up in the work we do without us even realizing it. Are we giving that person autonomy to know what is best for themselves and allow them to choose their own goals? Can we still treat people with care if those choices and goals go against what we think they should be? It really is up to us as providers to foster this sense of safety, which may involve shifting some of our policies or requirements to become much more low barrier. Actually getting input from the people we are trying to serve is always best. There's a saying in harm reduction, nothing for us without us, and I've found the greatest successes work when we allow our programs to shift along with that feedback. Next, please.
What would make you feel safe?
Ooh.
Transportation. Worried about not making it places. A big one is confidentiality, the way a facility is set up. A safe injection facility.
I'm sorry, it sounds like some of you guys cannot hear me, but I am in my outreach van on a Wi-Fi, so sorry. But let's pause and talk about that next section. Basic needs are a big struggle in this community. And we heard these same themes in the first summit's narrative as well. It can be really difficult to focus on improving mental and physical health when the basics that lead to safety aren't being met in the first place. Confidentiality is another word that sticks out. It's always important to be intentional with the space we work in with participants and always keep this in mind with program design. Drug use is deeply personal to many, and a lot of people don't like sharing this part of themselves with the public. This is absolutely essential when providing sensitive services like syringe exchange, but can also be a really big challenge depending on what your space looks like. Next section, please.
What is the biggest misconception about people who use drugs? They think we're all dangerous, diseased, full of sores, dirty. We're unwelcome in most establishments if they know we're drug addicts. That we're all dirty and gross, that we're all the same, that we're all thieves and bad. That we don't care about ourselves or others, that we're all the same. We're not all the same. We're not all bad. I work 40 hours a week. I just have an addiction. I don't like being labeled.
So this section was very heavy. What strikes me is hearing the same words over and over again. These interviews all happened at separate times with people totally unrelated to each other. No one had heard what the other answers were, yet you hear those same keywords from almost every person. That is telling us something loudly, and I think we really need to listen to why folks are internalizing these words. Dirty, dangerous, diseased, covered in sores, thieves, don't care about themselves or others, unwelcome, all the same, labeled. When people are given access to low barrier services with things that will improve their lives, they actually do pursue those. And we need to give credit to those folks who make safer and healthier choices and really believe in their capacity to do so. Part of believing and empowering someone to continue reaching forward is giving them the tools and opportunities to do so. Next section, please.
Drug user health is complicated. Drug user health is full of miseducation. Drug user health is in need of reform. Drug user health is challenging. Drug user health is equally necessary.
Everybody deserves access to equitable healthcare, but that's not what most people who use drugs experience. It certainly can be complicated and challenging, but there's so many opportunities to improve the level of care everyone gets. There's a lot of misinformation about drug use that gets passed around within communities, and there are also so many things about drug use that rarely get talked about at all. Some regions are rich with harm reduction programs and have way more access to services and resources. Other regions don't have any of these programs, and the communities suffer for it. We're in an exciting time where more financial resources are being funneled into creative solutions for people experiencing substance use disorder. But at the same time, we see some communities and leadership balk and pull back from these types of programs due to the population they serve. We must approach this public health issue using science, not stigma, and actually address the very real problems people who use drugs face day to day, instead of ignoring or condemning them. I'm so grateful for ADAI and the planning committee for putting together this summit to elevate the voices of people who use drugs, and for the presenters who shared their stories, as well as the audience for taking the time today to listen and engage. As we choose to work within this group, It's vital that we take into account the experiences people face daily as they work on surviving and thriving, and break down the barriers to care by really trying to foster a safe and supportive environment. People's lives truly depend on it. Thank you.
Thank you so much, Christina, for sharing those incredible stories and narratives with us and for helping us better understand the context and real lives of the people that we serve. Really appreciate it. Now I'd like to turn it over to Susan Kingston with Alcohol and Drug Abuse Institute and Brad Finegood with Seattle-King County Public Health to introduce the panel and facilitate a series of questions. Thank you so much.
All right, good morning, everyone. Can you hear me, Lisa and team?
Yes, we can. Thank you.
Okay. So on day one, if you remember when Caleb presented the results of the 2019 Syringe Exchange Health Survey, you may remember that only 1/3 of participants reported having permanent housing, which is not surprising, but it's still astounding that 2/3 of those participants reported having temporary, unstable, or no housing whatsoever. And then I'll also refer back to the planning survey that we conducted in December. My sense of time is so blurred right now. December of 2019, when we were first putting together our concepts and ideas for this summit, we asked in the survey if we could focus on something in particular. What would you like to focus on? A special topic. And the number one answer to that was housing. And I know that myself, when I hear that term housing, I deflate. And I think a lot of people have that feeling of, oh, it's such a big problem, such a big need, and so complicated and complex to address that need for our folks. So luckily, we have our panel here today, facilitated by Brad Finegood, to help explore this topic a little bit more. So with that, I'm turning it over to you, Brad.
Thanks, Susan. Hi, everybody. Brad Finegood again. I forgot earlier in my introductions to self-identify. In addition to working for Public Health, Seattle-King County, I'm also the person with the beard that Caleb Bantagreen is most envious of. So I just wanted to make sure to get that out. Anyway, everybody, thanks for joining us again for our housing support. Susan, thank you for kicking us off. I'm going to introduce the panelists, and then we'll go around and start asking some questions. If you have additional questions throughout the panel, I invite you just to type in some questions in the chat, and I will attempt to moderate it appropriately. It was really important when setting up this panel also for us to talk about the continuum of different types of housing services, all the way from 100% recovery-based, abstinence-based housing to sort of treatment supports and housing that go along with treatment, to permanent supported housing in so many different ways. And so, so I'm honored to have the guests with us today. Ellen Mua is the co-founder and executive director of the New Earth Recovery in the Skagit Valley. Ellen is also chair of Walker, the Washington Alliance for Quality Recovery Residents. The primary mission of Walker is to promote the establishment, successful management, and growth of high-quality, community-based recovery residents in Washington State. I also sit on the Washington Recovery Alliance Board of Directors with Ellen. It's super important to note that the recovery housing across the state and nationally has also been besieged by less than quality housing that has taken advantage of people who are vulnerable. And so the work that Walker's doing is trying to stabilize that. So Ellen, thanks for being here today. Dan Sigler. Dan is the Spokane Regional Director of Pioneer Human Services. Pioneer is an entrepreneurial human service organization that provides a chance for change to people overcoming the challenges of criminal histories, substance use disorder, and mental health issues by offering treatment, housing, training, and employment services. As a leading organization in Washington State that has offered an integrated array of services, Pioneer provides more than 10,000 people a year with the tools they need to better build lives. And as you can see, this panel is built with really a focus on geographic diversity from Skagit Valley pioneers all over Washington State. Noah Fay is the Director of Housing Programs with DESC, Downtown Emergency Services Center in Seattle. DESC works to end the homelessness of vulnerable people, particularly those living with serious mental illness and SUD. Through partnerships and an integrated array of comprehensive services, treatment, and housing, we give people the opportunity to reach their highest potential. At DESC, uncommon efforts produce uncommon results that eliminate the homelessness one person at a time. And lastly, Dr. Seema Cliff-Asefi is an associate professor and director of the Harm Reduction Research and Training Center at the University of Washington Harbor View Medical Center. Her research lies in the intersection of substance use, mental health, criminal justice, and housing policy. Since 2006, she's been part of several collaborative academic community-based research partnerships evaluating the effort of individual and community level harm reduction programs and interventions designed for people with lived experience of homelessness and substance use problems, including Housing First. Dr. Cliff-Asefi was one of the authors and evaluators of the Downtown Emergency Services Center 1811 permanent supported housing. So here's a question for you all. From your perspective, why does housing continue to come up as one of the most important aspects for people who use drugs and people in recovery? Alan, we'll start with you.
Sure, thanks, Brad. First of all, I just want to say a couple obvious things. It feels important to note that shelter, of course, is a basic need. So without it, it's nearly impossible to progress in life, to think, to plan, to maintain a person's security of themselves or their possessions, much less to take on just really significant self-improvement goals like recovery. It's also, I just have to be said, and I think the reason why Susan just alluded to how sad it is to think about housing sometimes is that it is much harder to find affordable housing than it's ever been. That just continues to be a theme that we hear over and over, even for providers of would-be recovery housing facilities. They just can't find spaces to rent, much less purchase. So it's been a real struggle. And speaking specifically about recovery, which, as Brad said, is my little piece of the pie in this conversation, we can have the best research-based inpatient treatment and the most redemptive and holistic judicial sanctioning. But what happens when a person leaves those institutions, either treatment or correction, generally speaking, we believe is more important than what happens inside. In other words, when they're launched from those places, what happens in recovery is going to be dependent on where they land. We really believe this is true. This morning I was sitting in a group with in one of our recovery homes during our morning meditation. I just asked the guys this question because I knew it was coming up today, and they said a lot of things. They talked a lot, but essentially they said, without a housing environment, I know that I would be right where I was trying to sort of live out a recovery journey in an environment, even if it wasn't dangerous. It wasn't for all of them, but it certainly was triggering to them. It was the environment that took them to the place that was so harmful for them. So that's probably it for me on that. There's much more to say. Any of these questions that you're asking can take a lot more time, but I'll turn it over to my colleagues.
Great, thanks, Alan. Dan, what about you?
Yeah, a lot of what I say maybe, somewhat similar, but I think that one of the reasons we're still having this conversation is, social determinants of health, which housing, of course, is a major one, plays such a huge role in the support that people need to recover or even to start contemplating recovery in the first place. And going back to, Brad, what you said earlier, we have decades of policies around the criminalization of drug use and mandatory sentencing for drug use or for drug crimes, which causes a huge disruption then to the connection to social determinants of health for folks. And once a person has a criminal history, they face all kinds of barriers to housing. Sometimes it's landlord policies around if you have a criminal history, you're not eligible. And even though we're starting to see some movement around that, which is hopeful in ban the box types of things around housing and employment, there's still much more there that needs to be done. But it's not only that, the criminal history then impacts access to programs that would help you with maintaining your housing, like access to funding for rental assistance is often limited or denied based on a person's history. So you first have this criminalization of drug use that then leads to having the criminal history, that then leads to all these other barriers once you're back into the community. So that it's going to perpetuate over and over until some of those things are addressed.
Thanks so much. Noah?
Yeah, thanks, Brad. Whoops, I'm still here, although my camera wasn't for a sec. At the risk of being redundant, I think we're hitting the points clearly. I think that the two driving reasons why housing comes up in these conversations is we don't have anything that resembles enough of it. And we know, DSC is based out of Seattle, and almost essentially all of our work is in the city limits, although we do work countywide. And we specialize in permanent supportive housing. And we know just in King County, we are 6,500 units short of what we assess we need for permanent supportive housing. And that doesn't even include the tens of thousands of affordable housing units we need for people. So, I try to, when talking with people outside of the housing homeless service sector, I really try to draw parallels around it being a platform and that resembles kind of what we expect of basic medicine. So the analogy that I've really found to be compelling for people is, imagine you go and you break your ankle and you go to the doctor and they give you all sorts of treatment and they give you a crutch or they give you a cast, but then they discharge you without a crutch and just say, figure it out. And I think that's a lot of what we have right now for people who are, lucky enough to access treatment, but don't have housing on the back door. They may be getting excellent care, inpatient or outpatient care, but if they don't have that platform to recover over the long term, they're just more likely to continue to struggle. And I think that is an analogy that people struggle to really kind of accept when we're talking about substance use, and that is invariably tied to the stigma associated with it that we don't see associated with other sorts of medical conditions. So, just really emphasizing that, to expect people to be able to make major life change while also experiencing the inherent trauma that is homelessness really just isn't reasonable. Certainly people have been able to do it, but I think being able to point to that we know the state of homelessness, experiencing homelessness, or even housing instability, frankly, is traumatic. And what we know about trauma means it's much more difficult for people to make major life change. And so until we are able to relieve that trauma, and the solution to that trauma is invariably housing, and given that we don't have enough of it, we're going to continue to have this conversation.
Thanks. I'm so honored actually to facilitate this panel because we know the impact of housing, but also I get to make comments all along out loud. One of the things that we've continued to hear is that people use drugs often at night to stay vigilant and so that they don't become vulnerable. And so that then further perpetuates the cycle of increased use. We know through public health, one of the trends in data that we've seen is many people using multiple substances, not everybody, but really the days of, I only use this drug specifically or this drug specifically are I wouldn't want to say in our past, but it just, the layer of housing insecurities and vulnerabilities that go with that make ceasing use more difficult because it becomes a survival mechanism.
Yeah, I could share an anecdote about that. Long story short, we've made some major changes to our shelter programming. DSC also does a lot of shelter programming in response to the COVID pandemic, which one of the biggest changes has been to move people out of congregate shelter and into hotels. There are two men I was talking to 2 weeks ago who just casually, I knew from our experience in our shelter here in downtown Seattle, who've since moved into a hotel with a door that closes, said they just stopped using methamphetamine because they were using meth because they were afraid to fall asleep and what might happen to them in a large congregate setting, let alone being outside. And because they're able to close a door, all of a sudden their ability to cease use or decrease use just became so much more dramatically easy for them, which is so intuitive when you take a step back, but in it, that seems like a bit more of a controversial topic.
Yeah, thank you. Dr. Seema, from your perspective, why does housing continue to come up as one of the most important aspects of?
Yeah, I echo everything that my colleagues have said to this point. One thing I will add just from the research perspective is that I think a decade plus of research really tells us that housing is healthcare. And when people are given low barrier supportive housing, like what Noah is talking about, they do better. They reduce their substance related harm. They make fewer visits to the ER, jail, detox, you name it. And also then the community benefits from that too. The 1811 Eastlake evaluation showed us that in the first year of operation, taxpayers saved over $4 million. And so, while I don't like to hone the capitalist perspective, I think that is an important, because we live in a capitalistic society, we can kind of show the positive impacts to the economy in that way. But first and foremost, housing is healthcare. And for all the reasons that my colleagues have talked about, it is important for stability, and it really is and should be a basic human right.
Seema, there was a question, if you could be so kind as to describe what 1811 is for those people who might not be familiar.
Absolutely, and I will, Noah, you can back me on this too, but 1811 Eastlake is permanent supportive housing, also known as Housing First. So it's low barrier, non-abstinence based supportive housing with wraparound case management services for people who can obtain those services if they want, but it is not required. So it really is based on the premise that housing comes first, and then there are other opportunities available to people should they want those opportunities. So that's, when you hear Housing First, so 1811 Eastlake was one of the first single site, which means that they have 75 units in that particular building. 1811 Eastlake was opened in December of 2005. And essentially for that particular house, people who were had lived experience of chronic homelessness and alcohol related problems were primarily offered housing, this type of housing. And then our team was invited to do an initial evaluation to say, is this kind of housing helpful or useful for people? And so that started my own personal journey in the research on Housing First. And here we are, what was that, 2000? So yeah, 14 plus years later, my research has focused on this model of housing in collaboration with DESC, and I've worked with Noah for many, many years, and Daniel Malone, who's now the executive director, and Bill Hobson, who was the original executive director at the time, and really pushed for this model of housing.
Great, thank you. I'll share a little Bill Hobson moment real quick. So for those of you who don't know, Bill Hobson, as Seema was saying, was the executive director and is now passed away of DESC, and was really one of the forefathers on the forefront of this idea of permanent supportive housing really throughout the United States. And so when I first came to Seattle, King County, and I met with Mr. Hobson and team, coming from out of the area, only knowing from what I had seen and heard through press, I said, hey, so I heard that this, can you tell me more about this quote unquote wet housing? And the room went quiet. Everybody looked at me, and Bill said something that really resonated with me today, which is that if I invited you over to my house and offered you a beer, would you call my house a wet house? And so just remembering that, the words and language that we use sometimes and unintentionally may be stigmatizing, and the way that we think about different interventions. And we really should think about this from a human-centered perspective. And would I expect things differently from other people than I would for me? So just a thought. So next question, and I am a firm believer and a big believer of different types of housing models across the continuum. So please, can you describe your model and give an example of a person who has done well in your program? Let me start with Dan on this one.
Great. Well, yeah, our model at Pioneer really focuses on the continuum of housing, treatment, and employment supports together for people who are returning to the community from incarceration or who have a criminal history. And but people come in, though, in a lot of different ways. So I don't know that I have a specific. There's many different examples of things that work well for different people. I think it's just different for everyone. But in Spokane, we have a number of permanent supportive housing units that specifically work with people when they're returning to the community from incarceration. And within that, we have voluntary supports. We kind of follow a permanent supportive housing model there. And the way that's worked, I'm thinking of one individual who he came to us. He was first released into a federal reentry program in Spokane. And while he was there, the staff there just helped with him getting some basic employment resume and interview skills that he'd been incarcerated for some time, so he had needed some help with that. And through that program, that was a transitional period, he was able to get employment and he was doing really well in that environment. And then he eventually moved into our permanent supportive housing program at the Carlisle. And the staff there just did a really good job of just engaging in relationship with him so that there was a good trusting relationship. And at some point along the way, he'd probably been employed about 8 months now. He had started using meth again, and staff saw that something had changed. But because there was a good relationship there, he eventually just kind of let them know what was going on and said, I need some help, but I don't want to lose my job. I don't want to lose my housing. And if I lose these things, things are just going to go so downhill for me. So they were able to work with him to get into an inpatient program that Pioneer operates in Spokane, Pioneer Center East, and also get some funding to help cover his housing costs while he would be an inpatient. And then, so he was able to go into inpatient, get some help there, then come back to his housing without losing it, which that's always such a big problem, is that if I go into inpatient and I lose my job, then what am I going to do? So in this case, there was some funding that we were able to find that helped him maintain his housing. And then in the process before this, he had lost his job because he stopped going to work and started missing a lot of work. But up to that point, he had done really well there. And so when he did get back out of inpatient and back to his housing, we worked with him to go back and talk to that employer because he'd had a good reputation up to that point about what had occurred, and the employer, was willing to hire him back. And so he's able to, regain that employment. But I think key piece to that is that, housing was central. Having that ability to go in and get help in inpatient and still not lose his housing was a critical piece of that. And having staff and a relationship with staff that weren't judging him for his drug use. So he felt safe enough to say, no, I am using and I'd like to get some help. That was an important piece as well. So that's one example of an individual that would do well in our type of program.
Great, thanks, Dan. Great example. And also the example of how stigma continues to perpetuate at times and place barriers unnecessarily up for people. And when stigma can come down, that people can feel more comfortable in their care and more comfortable self-disclosing of what's going on. Thank you. Noah, the question, describing your model and give an example of a person who does well in your program.
Yeah, thanks. So our housing model is really geared towards targeting the most vulnerable people who are experiencing homelessness in our community. So that typically means people living with co-occurring disorders and oftentimes very lengthy histories of homelessness. So a lot of trauma, both from experiencing homelessness and also sometimes other often childhood related trauma as well. So people who are coming to us with some pretty major challenges, and that is who we are intentionally looking to serve. And so our model is really designed at identifying that population, whether people are necessarily seeking services or not. So it's very outreach based. We're not necessarily looking for people who are the most inclined or cooperative, to use maybe a loaded term, but instead to find the people who are the highest service needs and bring them into housing. And that housing model is, and Seema touched on housing first, is a housing first harm reduction model. So housing first is as simple as it sounds. I mean, it's really the idea that the first thing you do if someone doesn't have a house is you give it to them, no questions asked. And so the model there is, there's really as few barriers as possible to move people into housing. But then once people move in, it's on us as the on-site housing provider, and we have partnerships with our own internal clinical agency and then other behavioral healthcare providers and healthcare providers in the community to assertively outreach people on a voluntary basis to engage in care. So there's no requirement whatsoever that people participate in care. Instead, it's on us as the service provider to design a treatment model that people want to participate in. And that really runs the gamut from what might look like fairly traditional outpatient care all the way to some very creative, assertive outreach efforts to try to help people stabilize in their housing. So the whole model starts with the idea that we need to find a way to do whatever it takes to keep people in housing. Back to my earlier comment about seeing it as the platform by which recovery can happen. If we keep people housed, we allow them the opportunity to reach their highest level of self-sufficiency. So the model is on a voluntary basis, design services that are really aimed at keeping people housed, and then from there, connecting people with whatever other care in the community people are interested in, totally on a voluntary basis. And clearly married to that is a harm reduction model. So I struggle to understand how you can do housing first without doing harm reduction. To me, that's a core component of it, and it can be defined, as I'm sure this whole group knows, any number of different ways. But for a housing provider, for me, when thinking about how to run, and as Seema touched on, a lot of our programming is site-based, meaning it's a whole apartment building. And so we have to find a way to enforce leases and keep the program safe. So how to do that, where people very well may be engaged and often are in pretty active substance use. We really separate the behavior consequences from the substance itself. So we really tease those two things apart and try to treat substance use as a clinical issue and impacts on the community as something that we create, hopefully pretty creative solutions to avoid the impacts on others so people can keep their housing.
Great, thanks. Alan?
So the segment is in the introduction, Brad said, so the segment I represent is referred to as recovery housing. So as a subset of the larger group that we're talking about today, recovery housing really refers to the group of us who, for whom our residents basically say that their goal is abstinence and long-term recovery. But within that category, there's a wide range of, it can look like a lot of different things. So everything from Oxford housing, which most of you know is essentially peer run, low level of sort of formal care and programming within residences, but a high level of personal connection that really many people have found to be life-saving for them, all the way up to programs that have a lot more structure to them, including life skills components, conflict resolution, skill building, job search assistance, case management at all kinds of levels. So the recovery housing as a general label applies really broadly. A lot of different types of providers in that tent. And so that said, I think I'll stick to my own sort of personal experience there, and thinking of, dozens of people who have graduated our programs who are doing really well today in long-term recovery. And I know of hundreds, even thousands of folks who have gone through other providers and Oxford and so on in our state that are doing really well. But one resident came to mind, who was, she grew up on a reservation here on the west side, and essentially due to her own parents' drug use, ended up largely raising her younger siblings from a very early age just has a really traumatic story in so many ways. We don't have time to go into the whole thing, but essentially she came to us, and the first question she asked is, boy, what if I'm too broken to fix? That was an honest question that she asked, which just, of course, just motivated us like crazy to say, there's nobody too broken. We want you here. And so she just started to grow and started to, someone alluded to this earlier, but the recovery process is so much about building trust and learning who to trust, trusting people again. In her case, she learned to trust other women in the house, which was just a brand new set of skills and sort of vulnerability for her, and vulnerability in a positive way in most cases. And so she continued with us. At age 31, she got her first job ever at McDonald's, and I remember her saying, "Boy, why didn't I do this before? This is great." And she's working at McDonald's, and so it's just so telling about what kind of esteem comes from just being productive and doing things that many of us would just consider kind of normal kinds of things. And anyway, she became a manager there, did very well, worked there for several years. She had along the way earlier in her story lost her 3 girls because of her own substance use. And has since reunited with them. She was in that process while she was living with us, doing visits and so on, very close to losing them permanently, but thankfully was able to just get into recovery in a way that made it possible for her to reconnect. She graduated our program a couple years ago. She's still in pretty regular contact, just letting us know what she's up to. She's doing very well, and her girls are, it is needless to say, doing fantastic, living with their mom and living regular life. So a lot of stories like that, but that one just is particularly precious to us because of the many ways recovery means so many different things, but there's so many dimensions to it. But she experienced most of them, and all of that we really strongly believe had to do with the environment in which she was able to feel safe and grow in and develop the trust that led to all those things.
Thanks, Alan. There's a question that came up in the chat that is Walker, or the Washington Association of Quality Residences, a resource for individuals looking to open recovery residences?
Yes. So we work on a few different fronts. One front is we do technical assistance for providers who are looking to start, and so we do that obviously these days a lot over the phone. We have a document library that can help people just sort of get started with policy formation, all those kinds of things. And we are not prescriptive about recovery philosophy. There's a big tent, as I said. Levels of care vary quite a bit. And so we start by asking a lot of questions of would-be providers. What is it that you want to do? And then we go from there. And then also on our website is a directory of homes that are accredited by us. So we have an accreditation process where people can find houses that have already been accredited. And so that there's some level of understanding that they've been through some process. Someone has looked through their policies and procedures, inspected their homes, gone through interview process to determine that they meet the quality standard. Thanks for letting me do the commercial, Brad. Appreciate that.
Oh yeah, no, I appreciate the resource. And again, we want to make sure that, when people come into recovery residence, whatever type of residence that is, whether that's a permanent supported housing where they might be working towards their own goals or more towards an abstinence-based style of recovery, or that they're on medication for their opiate use disorder and they're supported in that it's done in a quality manner and that people are not vulnerable and taken advantage of. So thank you for your work. And maybe if you could put in the chat box, Alan, the Walker website or something.
Sure.
That would be great. Thanks.
Be glad to.
Dr. Cliffeseffi, is there anything, I know that the Heart Institute doesn't directly provide housing, but anything in the models of care that you've seen through your research or anything of the sort that have worked well, evidence-based, promising practices, all of that type of stuff?
Yeah, so like I said, my entry into this work came initially from doing the research around the model of housing. And then we realized that people just don't stop using once they move into housing. Although we see reductions in harm, there's still work to do around that. And we're the Harm Reduction Research and Treatment Center. And so what we do is we really work, and DESC has been one of our biggest partners. So we work collaboratively with people who use substances, with the community members, and also organizations to really develop, co-develop, conduct, evaluate, and disseminate evidence-based practices that are related to reducing substance-related harm. And so what sets us apart from other sort of treatment spaces is that we do not ask people to stop using substances in order to get help. And we take a really collaborative approach to our research and our treatment development, where we recognize and value the unique strengths that people bring to the table, and we bring them to the table, especially people with lived experience, because we believe that no one knows better than individuals with lived experience of whatever it is we're researching, in our case, substance use, and also homelessness. So we bring those people to the table, and we work to develop approaches that are in service of reducing substance-related harm. And our work over the last decade or so has shown that we have been able to find harm reduction models, brief interventions where we are working alongside people to reduce their substance-related harm, improve their quality of life. And a lot of the folks that we worked with have been people living in permanent supportive housing.
Thank you so much. Thinking about this next question that I'm going to ask, I think about when I was in the behavioral health division, and we were responsible for working with treatment agencies to make sure that treatment was ample in the community, and starting up treatment agencies, and thinking about sometimes, the biggest challenge in starting some type of service is around community pushback, and the difficulty citing treatment locations that are evidence-based, that reduce crime, reduce drug use, all of that type of stuff in the neighborhood. Yet nonetheless, the stigma that was out there in the community about substances made it so hard to cite places. And so, my next question, and not to jade what your answer is, but my next question is for y'all: what is the biggest challenge in serving the members of our community? So, everybody represents a very geographically diverse area, from suburban, urban, rural areas. So for you, what is the biggest challenge in serving these members of the community? I guess, Noah, we'll start with you on this one.
Yeah, thanks. I think my reaction really is access to care that doesn't kind of reaffirm some of the really well-placed mistrust that a lot of our clients have in the system. So we are lucky to be in King County. There is a lot of stuff, but it doesn't mean it's very accessible to the people we're looking to serve here. One of the first things I really try to kind of always remind myself and the people that we're working, the team that's working here, is that our clients have a really well-placed mistrust of the system that is well-deserved. It is not unlikely that people are rightly skeptical about engaging in care, and so we need to find ways to design care that goes to people. So to me, I think that the biggest barrier is finding providers who have a service modality that really speaks to the complexity of the people we're looking to serve. There aren't a whole lot of those, and really trying to find ways to co-locate, develop deep partnerships. Co-location has been something we've been doing with primary care quite a bit, and that's been remarkably valuable. Several of our programs are in the heart of Pioneer Square, and we've been partners with Harborview for decades, and Harborview has Pioneer Square Clinic literally 2 blocks away. And the difference in access of care between having a Harborview clinic in a program versus having a clinic 2 blocks down the hill, it's remarkable. And it just speaks to people's reluctance to engage in a system that hasn't met their needs for decades. And we really have to find a way to outreach and draw people in. And that takes time. And frankly, funding models and payment models don't necessarily really support the outreach and engagement work that it takes to build that trust, which I've heard 10 times, and we should say it 100 times, as to find a way to build that trust and rapport is really critical. And there isn't necessarily an easy way to pay for that. So that is often one of the barriers that we see.
Great. And it just sort of illuminates systemic structural problems to our system that make it where we know what works or we know what's helpful for people, but sometimes the structures in the system don't make it easy to do that work.
Exactly.
Thanks. Seema, what are some of the biggest challenges that you see in serving members of the community?
Honestly, pre-COVID or post-COVID? Yeah, right now.
I mean, both, right? I mean, I think they're both pretty appropriate.
In all honesty, I would point to our failing treatment system for the vast majority of people who use substances. I mean, we know like there's something like 20 million people who have a substance use disorder, and we know that there's only about 2.3 million people who actually receive treatment. And of those people, the 90% of Americans who needed but didn't get that treatment, 95% said that they didn't need it. And the number one reason why people didn't get it also is they didn't want to stop using substances. And our treatment systems are, we are very based in an abstinence model, although here in Seattle, we are, we have a little more openness to harm reduction models. But I would say, I mean, those are some of our biggest gaps, our current treatment system, basically failing our substance using population. And really, we need to come up with different pathways for people to reduce their substance related harm and improve the quality of their life. And so I would say that is our biggest challenge. Stigma, as you were talking about earlier. So yeah, I'll stop at that to have my other colleagues share what they think.
Thanks. I sort of feel like you could have kept going there a little. Thank you. And you think about some of the things you said around the treatment system, and it is what type of treatment and the types of treatment models, but also access to treatment system and barriers to the front door. I think about for years and years and years, much like that of housing, you needed to be abstinent, have urine testing that proved that you were abstinent from drugs, or else you were kicked to the curb, for better or worse language. So thinking about, the challenges that we impose on ourselves as a system, it is very difficult to do the work that we are doing. And especially, as Noah's talking about, in a way that DESC does it with a population that has so much complexity to it. So it really, it really presents all these sorts of challenges. Absolutely. Alan, what about you? What's some of the biggest challenges in serving the members of our community?
I want to just pile on, if I may, just for 1 second around abstinence and say that there is some good thinking going on in the recovery housing community about fresh approaches to that. So I guess I want to, instead of presenting ourselves as sort of far out on a continuum over here, sort of harm reduction and housing first over here to straight abstinence over here, where they're near the twain shall meet. I think that there are a number of us really thinking through bigger picture questions around what's the best way to help somebody and so on. So I just want to be able to say that to the group, that I think there's certainly policies out there that, around sort of the 15-minute departure rule on use and all of that. And that's a whole other can of worms. But I just want to say that there are a number of us really doing some exciting things in terms of rethinking those sort of hard and fast rules of the tradition. So anyway, I thought there's a huge question you ask, and so I want to answer it in maybe a non-conventional way. But I think the biggest challenge that we face in recovery housing is the challenge of the trauma that people bring to the table when they come to live with us. And I'm just growing more and more convinced that the better we are at providing safety, and that is just a lot more complex than we used to think it was. So just getting somebody into a residence doesn't mean it's going to be a safe place, doesn't mean it's going to be a place where they don't experience more trauma. So I think our biggest challenge is to educate ourselves in what it means to do what we do to help people heal in a way that really addresses trauma that is so often at the root of what's going on in terms of their substance use. So until we get better at dealing with that, we'll simply prolong kind of what I would call detox, right? Essentially what in the recovery community we would call sort of white knuckling recovery, which is not dealing with the root issues that got people there to begin with. And so it's a tall order, and I don't pretend to be an expert, but the more we experience more success, the better we get at really acknowledging and working through trauma with residents. The challenge in all of that is that many of our residences, as we talked about before, aren't staffed. They're not particularly, they provide peer support, which is excellent, can be really good for folks. But providing that level of care that actually would make a lifelong difference in somebody's story who wants to move into recovery in all meanings of that word is going to be it's just a big challenge for us. So the more you know, the harder this gets.
Yeah, absolutely. And there's so many challenges that take place. One of the Tony Walton said, in no other healthcare delivery model is somebody denied services for displaying symptoms associated with their illness is done with substance use. And it makes me really think a lot about one of the major critiques of some housing, and not pointing fingers at any of the panelists or needing necessarily a response, is that, for as we have been working with, to increase access to medications for substance use disorder as a whole, there are many houses which put barriers up for people who are on medication for opiate use disorder in specific, but other substance use disorder. When there are so many ailments, we don't ask people not to be part of a group because they take ibuprofen for a headache, right? Or some other type of medication to address symptoms of maybe of some type of ailment. And so, the way that we think about and the way that we use language to help to help reduce stigma and reduce barriers for people, especially with one care provider saying this is the best situation and a different provider saying otherwise. So really thinking about substance use disorder as a health condition that we can provide services and help for, and housing being supported that. Absolutely. Great. Dan, what about you? What's some of the biggest challenges in serving the members of the community that Pioneer serves?
Well, I think that, addiction it's chronic and hard to recover and difficult no matter who you are. And, but then when you add in the types of barriers that we're talking about due to stigma or so many other things, that just makes it so much more difficult. And when Noah was mentioning kind of different models, some of the co-located models and some things like that, we've experimented with some things like that. And it does, that does work so much better, but it just requires a lot of resources. But I guess my feeling on it is that, the resources are out there, they just tend to get spent in different places. And that's where I feel like the criminalization of drug use, seeing so often where a person going back to jail for a relapse or something like that disrupts the whole continuum. And so I feel like that is just, that's a major piece that makes it difficult for serving people when that disruption happens, and for providing that support. And then, like I said, that creates so many other barriers. So I think part of it's systemic, and then the other part of it is that you could put resources that are going towards the criminal justice system in a different direction that could help people maintain their housing and their stability in the community, when going to jail is just going to make the problem worse.
Thanks. Seema, what are some of the big challenges you see in serving members of our community?
I think you already asked me.
Dang it. I was like, I was losing track
Stigma.
of the conversation that we are having. You know, one of the things I'll say, and that reminded me of something that Dan said, is personal experience. When I first started working 20 years ago in substance use disorder field and working in groups, I remember working with an individual who was before a judge in a therapeutic court model, and he had used alcohol when he wasn't supposed to use alcohol, and the judge said, hey, we're going to have a therapeutic intervention, and we're going to have you go to jail for this weekend, and I really want you to think about it. So we were talking about it, and I'm like, all right, I want you to come back next week and tell me, you know, what you learned from this experience. And so the person came back next week, and I said, okay, how was it? You know, did you learn anything? Did you take anything? Were you intentional about it? And he goes, yeah, I learned how to make meth. You know, and you think about, you know, putting people in an environment that is not promoting their well-being and is not in a good situation. The impact of the legal system and criminal legal system involvement, you know, can be detrimental and trauma inducing for people. Okay, so I got one more question for you all, and then we're going to move on. Dr. Kofasefi, I'll start with you. And the Heart Institute, how do you partner with other service providers to support a continuum of care? What do you need to strengthen those partnerships? And I know that your work is not only with housing, but is with the full continuum of providers around harm reduction, from places like sobering or harm reduction, engagement to treatment.
Yeah, I think, I think partnerships are the key to really figuring out how to best serve people who use substances and really promote their well-being. I'm really proud of the partnership that we have established with the Downtown Emergency Service Center over the past decade or so. And I mean, like any partnership, right? It involves communication, understanding, you know, where people's strengths are and what services they're trying to provide, so that, you know, we're not recreating any, recreating the wheel, as you might say. So it's really about, like, for us, it's really about listening to what the community is asking for, figuring out how we can work within that system, figuring out those systems. I mean, I know these are very generic, this is a pretty generic response, but really that is our approach, is like, listen to what the community is asking for, and then figure out how we can provide those things if that falls within our particular domain. And I would say most of all, really listening to the affected community members. So people, again, I want to bring it back to people with lived experience, to really hear what they have to say about their own care and how to best support that. And so I think that's what I would say about how we go about our partnerships.
Great, thank you so much. And it just really goes to show, and the work that you all have done and that Caleb does with the Alcohol and Drug Abuse Institute and so many academic institutions and research institutions, is the importance of research and evaluation when talking about programs, because it's so easy for community members to say that doesn't work, or that doesn't make sense, or that might feel counterintuitive. But for us as a group and as folks who are really who really care about the care that people receive who are using drugs, to be able to say this improves care, this improves outcomes. It might not be the exact outcome that somebody might want to see, but there are so many other positive outputs versus the standard of care, which might lead to worse health. Or it's also important to say that this doesn't work and that we need.
One more addition, and this just brings me back to Bill Hobson again. I mean, he had to be willing to open up, you know, he was very convinced that providing housing to people who use substances was going to be helpful. But he was also willing to be wrong about that. And so he invited our group to say, you know, hey, if my gut feeling, I want the science to actually tell me if this model of housing is going to work. So I guess you have to be willing to be open that maybe the model that you're using is not going to be best serving the community, and then be able to be kind of nimble within that. And so I always think about, you know, this was something that Bill was so passionate about, you know, promoting housing first, and he talked to politicians, and he really, you know, but at the end of the day, he was like, I'm going to invite third-party evaluators to come in and tell me if this model is working. And I think that really showed great kind of braveness, and also a humility of, you know, if this isn't the right way forward, I want to know what is, and I want to figure that out. And he was right. It was a right way forward, this housing model, but he was willing to be wrong. So I think that's important in the partnerships as well.
Great, thank you, Seema. Noah, what about you? How do you at DSC partner with other service providers to support a continuum of care?
Yeah, I'll try to avoid a generic answer. Because you get in the weeds real quick, but it's critical to do. And I think a couple things come to mind thematically. The first is recognizing that we all have our own language we seem to use. And so it's maybe the easiest thing to say, but trying to get out of our world of jargon and try to find a common shared language so we can communicate across sectors. It's amazing. DSC is lucky to be a behavioral healthcare provider too. And I do our housing work, and I have a peer who runs our clinical programs, and then we partner with primary care healthcare providers, and we all say the same things in many different ways, even though we've been working together for 40 years. So trying to find ways to share our language in a way that is easier to communicate is great. I think then logistically too, I think even when the continuum of care has been established, our philosophy has long been that we can't set it up without helping people find ways to navigate that system. So, and I think some of that goes back to that these systems are complex, maybe because we use goofy language, doesn't help. But then also, you know, like we've touched on, we have a lot of trust to rebuild with the people we're looking to serve. And so finding people who can help navigate that system, literally going to appointments with people, literally making those connections, walking in lockstep with people to ensure we're not just making referrals, but we're doing warm handoffs and making sure those relationships stick. It's kind of built into our model. That's one of the key things that our housing staff do. And then something that I think we always really pride ourselves on, and it's building off what Seema said, that I would just really extend my appreciation for the work that Seema and Susan Collins have done at DSC for the last decade or so, is really ensuring how we're making decisions about program design, center the voice of the people we're looking to serve. I don't think anyone disagrees with that. That is just a lot harder to do than it is to actually say. And so to make that happen involves really intentional work that can be difficult to get the meaningful kind of feedback you really need. But in order to really create a continuum of care that meets the needs of the folks we're looking to serve, really centering that voice takes a lot of work and effort, but it's invaluable. It needs to be done. And so that would be where I'd start. If we're looking to figure out where to build partnerships, we'll go to the people we're looking to serve and figure out what is it that they need and what isn't there for them. And even if it is there, where's that bridge broken and how do we rebuild it?
Yeah, thanks. I mean, and you know, the bridge, you know, between agencies to service providers, but also the bridge of the on-ramp into the system, you know, Noah, when you were talking about the number of housing units needed versus what an agency like DSC or another agency provides, how people who are in, you know, the throes of substance use disorder or may have other challenges that they are experiencing, how to access even the on-ramp, you know, and then once they're on, how to access transitions of services so that people do not drop. Super important with partnerships. And, you know, and that's another place, you know, a lot of conversation at the last meeting we had a couple of weeks ago was about the use of peers and other types of navigators and services, and that also has to be funded. So thank you, appreciate it. Dan, what about you? How do you partner with other service providers or support a continuum of care? What needs to strengthen what needs to happen in order to strengthen those partnerships?
Yeah, I think that, you know, I'll make a broad statement first and then get more specific, but I think that one thing that has been really great, and I don't know if any of these folks are on in the conference here today, but Better Health Together, which is our Spokane's ACH, Accountable Community of Health, has just done a tremendous job of bringing together the whole system in terms of the healthcare system and behavioral health and social determinants, the education system, all of those into the same room. And that in itself, just that ongoing regular getting together with people from those organizations has resulted in just quite a bit of new, partnerships and innovative partnerships that have really helped with the continuum. I mean, it's so much more is in place now than I think was a couple of years ago. And a lot of that was around the Medicaid integrated managed care push. So I think that's been a good thing. And then I think one area that has ended up working out well in a partnership for us that kind of looks at the continuum is with MultiCare. We have a partnership with them where when they have someone who is in the hospital who, say, for example, needs to complete a series of 8 weeks of antibiotics due to an infection and is an IV drug user, but isn't ready or wanting to go to treatment and they're homeless, they call us and we'll engage a chemical or an SUDP or substance use disorder counselor will go in and or a peer and just start meeting with the person if they're open to it, building the relationship. And what we've seen on a couple of occasions now is where people are kind of in a pre-contemplative stage when they're there, but we're just building the relationship. There's no expectation. There's no, you have to go do this or anything like that. But where by the time they get 2 weeks into their antibiotics, they decide, you know what, they do want to get some help and some treatment. And then, the healthcare system has been able to help us through providing some of the support in the inpatient setting for the medical part of it. And then the person is able to go into substance use treatment in one of our programs. And then, so that's one example of something new, I think, that's come into place for us, where there's been a new partnership created in the continuum. But that's not without its challenges. And learning that when Noah was mentioning a moment ago, learning the languages, the different languages, the different groups are speaking, takes some work. And it's incremental steps. But those are, I think, a lot of the work towards integrated managed care. I know it's challenging and there's difficulties with it, but I do feel like I've seen a lot of good that's come out of it for a lot of us that wouldn't have otherwise put out our hand for a handshake or tried to make something work. And now a lot of new creative ideas are coming out of it.
That's great. I mean, and what a great example, Dan. Thank you. I mean, it's such a good thought about how we need to get outside of our silos of care and, treat an individual as an individual, because people have so many different needs beyond, housing, substance abuse services, mental health services, medical services. But the more that they can get their services in a comprehensive, one-stop shop manner, probably the better off it's going to be for people. I say that without the evidence in front of my face. It's great. Thank you. Alan, what about you? How do you partner with other service providers or support a continuum of care?
So I think referring back to the challenge that I articulated before about sort of trauma, and I would also add, of course, co-occurring issues, people in recovery from co-occurring disorders. They're just their road to recovery and just even their ability to be healthy is dependent on a lot of different things and a lot of different people involved in that. And again, the challenge on our end, especially for providers who don't have a lot of staffing or any staffing really on the ground, is how do we participate in that group or that sort of care that surrounds a person. But for those who do, and I'll use our little organization in Skagit County as an example, we invite our residents to fill out ROIs, releases of information for all of their providers. So mental health provider, detox if they end up back in detox. Certainly if they're on medications for opiate use disorder, we want an ROI with that provider. And so anyway, everyone who they're seeing, their primary health care provider, we want to be connected to those folks as well. And the goal isn't to talk about someone behind their back, but to be connected. So we're very upfront about that with them, and just ask our residents to be a part of those conversations as well, of course. There are times when some providers are more open to those relationships than others, and I just want to be honest there to say some don't see a housing provider as somebody who sort of has the chops or credentials to be in that conversation, and that's hard because we often have some real insight that would be helpful to them in doing their work. And so I think generally speaking, as we've developed credibility in our community and reputation for doing good work and caring about people and treating people well, we've kind of earned our place in some of those relationships. But I think it's been hard. It's been hard won, and it is working well these days with most providers in our area. But again, there are still some who just don't see sort of the bigger picture of what that relationship how that can be helpful to be in dialogue with us about our clients, our mutual clients. But in general, the times we have done that have been really fruitful. And again, I use the word invite. We invite our clients to do that. We don't mandate it; it's up to them. But we really want them to see that there's a team around them and to know that it's really for their good. And most of our residents are really open to that and want to be cared for in a way that is holistic. So
great. And it just also, as you were saying, it points to some of the where stigma exists around who is a healthcare provider, what type of care is healthcare, and how to coordinate services is super important, and going back to something that Dan said is, the ACHs have really helped bring folks together who wouldn't normally have a conversation as that idea of an accountable community of health regionally. And it's looked different in different regions, but that's sort of part of the beauty of it is each region has its own sort of need set. So I'm going to end on this. There was a question that got, you can't see it with my background, but sent into the bat phone that we're going to end on. And it's a question for you, Dr. Cliff-Assefi, to describe how you define harm reduction counseling and the place it plays in the continuum of counseling approaches. So, as we transition and move into this idea of how do we expand harm reduction counseling, how can you talk about, if you can talk about that. I think you're on mute.
I've given my answer. It's all good. Just kidding. Yes, the way I would describe harm reduction counseling is really this pragmatic and compassionate approach to working with the individual to really figure out ways that they can reduce their substance-related harm and improve their quality of life. And so what we do in our harm reduction counseling is really figure out with the person kind of what things they want to see happen for themselves and work with them to attain, and they don't have to be related to substance use in particular, because what we find is that when people are able to name the things they want to see happen for themselves and then work towards those goals, they're able to build that kind of confidence and self-efficacy to say like, hey, I wanted to see this happen and I was able to see this happen, like maybe I can do this, and adding to their confidence about what kind of changes they can see for themselves. The second piece is really trying to identify ways that person finding out about their unique substance use, looking at the pros and the cons for them, and really trying to identify ways to stay safer for that particular, whatever the constellation of substances that they're using. So really kind of trying to come up with strategies with them on what things that they can do or try to keep themselves safer or healthier if they are choosing to continue using substances. And so through our research, we've worked over the years with many people who use substances to kind of really come up with safer use strategies for different types of substances. And we recognize that each person is going to have, different situations and circumstances. So we really work it's very personalized, and we work to identify, what strategies are going to keep that person safer and healthier if they are choosing to engage. And I want to say also that we absolutely support if someone chooses as their goal that they want to work towards abstinence. That is absolutely, as harm reductionists, we can get behind that if that is coming from the client themselves and that's what they want to see happen for themselves. So, those are kind of, and we really just try to take the black box out of the treatment piece. So really like tracking with individuals, their progress, when we meet with them on the goals that they wanted to see, how well they were able to kind of stick with their safer use strategy plan. And we've identified, even with a 4-session intervention, so 4 sessions of working with people who were actively actively experiencing homelessness, that people were able to reduce their substance-related harm. And improve the quality of their life and move towards the goals that they wanted to see happen. Does that answer your question?
Yeah, absolutely. Yeah, absolutely. Thank you. And I just wanted to say in closing that how honored I am to have shared the space with the 4 of you today. You all do just such amazing work in the community with people who are experiencing substance use related issues or are on their path to recovery or manifestation of however that is. So on behalf of the whole Transforming Our Communities Committee, Alan, Dan, Noah, Seema, thank you all for your time today and sharing your expertise. There's been great conversation in the chat box about everything that we've talked about. And so I just wanted to thank everybody. Thank you for letting me share the space. And I'm going to send it back to Caleb.
Thank you all. Thank you.
Awesome. Thank you all so much. That was really, really wonderful. I think really shows both sort of the spirit that we approach the work with, as well as the very sort of concrete day-to-day operational things we need to work through. So, so what I want to take a little bit of time with now is talk about where we want to go with all of this work. And I will share with you that this process, this meeting is very different than anything that and I think most of us have done before. As I've said before, as primarily an academic, it's often about sort of conveying content, and this is very different. This is really a shared process that we all have ownership in, and so I want to talk about some ways to think about how to go forward. So one thing I'm just incredibly heartened by is sort of the level of participation, and that just is emblematic of sort of the interest that you all have in this work. We're seeing this from people from all across the state, and what I really value is people from different perspectives and organizations, and really importantly, the quarter of folks here who speak from the perspective of having lived experience, which is essential to drive this work. And so, as a governmental institution, we have some resources that we can help support some of this work. There are some things we can do. There are some things we cannot. We would really like to help support the work moving forward. And we also very much recognize that others will want to and should be driving this work, not-for-profit organizations and advocacy organizations. We're very happy to collaborate and coordinate that work, but it is essential that we do not co-opt that work and try to do work that is really the place for others to lead. So as you've already heard today, hopefully we are really very responsive to feedback. At the earlier example about how people are self-identifying that they have multiple perspectives. And so we really need and want the active participation of everyone. And I love the chats that are going on right now just really show that sort of the partnership and the connections that are already being made, which is exactly what this is all about. So, some of the things that we can help support, and I'm so glad we had Seema here to also talk about harm reduction counseling. It sort of immediately makes me think about, oh, here's another topic we can talk about, which are different counseling approaches. So maybe that'll be a topic for a future conversation. But some of the work that we're able to help with here at the Center for Drug Safety and Services Education here at ADAI, you saw the example, many of you last time, around needs assessment, the survey work we've done around syringe service programs. We would love to partner with other folks, both to find out what their organizations need, what their clients need, and there's different formats and forums we can do that. So I want to mention that that's something we would really love to help support. Developing materials. I think people are aware of the webpage we support called stopoverdose.org. We have a brand new webpage called learnabouttreatment.org that I encourage you to take a look at. And we're in the midst of building a number of materials right now as well around, for instance, the role of medications and treatment for people who are in jail, for things around stimulant overdoses or overamping. So there's materials and such, and we need to hear from you what you need. And then we can share this information, whether it's listservs or web information. We very much have an amazing dissemination group here at the Alcohol and Drug Abuse Institute. And then in terms of technical assistance, we can also be the sort of, where we can come in, just as Seema was talking about, there are things that are really evidence-based and driven, and so much of, there's a lot of good evidence-based work that we can do out there. A lot of the work that's being done isn't evidence-based. Some of that's because we haven't had the chance to evaluate it. Some of it is we have evaluated it and it hasn't been shown to work, and yet has become the norm or the standard in many communities. So that can be a real tension, and we want to help facilitate sort of that dialogue and where we can bring best practices to our work. And then facilitating meetings just like this one, except that hopefully one of these days it'll be in person. And that's really what I want to kind of lead into next is, what are the things that we want to do? And again, recognizing we are a really diverse group of people, and that is our strength. May make it a little challenging to build an agenda and make everybody happy in one meeting, which we will never accomplish, but we'll do our best. But it really is trying to figure out how to facilitate dialogue, as we're seeing happening here already. So I just want to share with you before I go into our next set of poll questions, which is really about where do we go from here. This is a very incomplete list, but it's just an example of some of the resources that are out there, some of the existing groups that are out there that I do want to make sure you know about. And as I go through this, the very last bullet point is please add others into this list, and we will also kind of collate this list and flesh it out with contact information and send it back out to everybody. But as we think about what we may want to do, really fulfilling the mission of this group around health, equity, and justice for people who use drugs and how we really transform our communities, what are the gaps that still you think are out there that we can help work to support looking at this list? So I'm just going to read down this list very quickly. As I've mentioned, there have been long-standing meetings, statewide meetings, prevention and treatment conferences sponsored by the Division of Behavioral Health and Recovery. There are prevention and treatment research work group meetings. So if you're really interested in research and evaluation, we really welcome partners. I co-chair the treatment research work group meeting with Mike McDonald from Wazoo, and we had over 40 folks, including healthcare providers, treatment providers, health payers, having conversations about these are the clinical issues we're finding, this is where we're finding success, these are the gaps, this is where we need evidence-based, this is where we have data we'd like to share and have explored. So we welcome people's participation in those meetings. The Northwest Addiction Technology Transfer Center is based here out of 8AI, directed by Brian Hartzler. Really rich resources around training, primarily for clinicians from different perspectives, which I encourage you to take a look at. As many people know, there are accountable communities for health across Washington State. They all have some sort of opioid group within them. Those are organizations with which I really encourage people to partner. And then the Washington State Opioid Response Work Group meetings. These have been going on since 2008. I've been participating in them since then. If you're specifically interested in opioids, I encourage you to join that. We're also very mindful about mental health issues and other substance use that overlap, and we're very welcome to having that be part of those conversations. There's a Washington Recovery Alliance, which also partners around recovery housing as well as recovery coaching. So it's another important organization to know about. Syringe services programs from the Department of Health we've talked about. Vocal Washington, which Malika Lamont helps direct, and that is an organization that's focused specifically and primarily, as I understand it, on promoting safe consumption spaces. There's the Urban Survivors Union, which has some affiliation also with the People's Harm Reduction Alliance, which started here in the University District and is now in many counties across Washington State doing a range of harm reduction services. In addition to sort of syringe services, they're also doing things around, for instance, safer use of methamphetamine. At our methamphetamine symposium a year ago, the use of pipes for methamphetamine as a safer use approach was discussed by Shiloh Murphy, for instance. And then there are supportive housing resources, which I'm not expert in and which I beg people to write in with other resources as well. The Department of Commerce certainly has some of that information. The American Indian Health Commission for Washington State is a really central organization thinking about the role of Indigenous folks and health and the relationship across organizations and entities. And so that's a very important organization to know about. And then please, if people will keep adding other things in the chat box, that would be great. And then I want to mention also, this is really important. You know, a lot of the work we've talked about has been around opioids, but I don't want to forget talking about sort of other illicit substances associated often for many people with both benefit but also substantial harm. And those include methamphetamine and cocaine in particular. And we also need to be mindful as we're thinking about these substances about the different populations who are using these substances and which populations get good or bad attention for that use. When I came into this work in 2001 as an epidemiologist, the focus was on rural white methamphetamine users, not talking about the pre-existing population of more urban users of color who are more likely to be using heroin and cocaine. So just really being mindful that we don't get too narrowly focused on a drug, which is really the symptom. And so I'm often mindful that even though I work at a place called the Alcohol and Drug Abuse Institute, the treatment of substances is actually about the engagement with a human being and finding out what their priorities are. And I think to Seema's point, and it's come up in our syringe exchange survey previously, people's priorities who use substances are just like everyone else's. They are relationships and housing and work and all of those things. And their substance use is something they may well want to be addressing, but while we as sort of the outside people who come in to quote help them often think it's the most important thing, it may well not be the most important thing. And so being cognizant of that and the much more holistic approach that I appreciate the housing panel speaking to. So that's just some background, and I want to lead now into these poll questions. And regarding the poll questions, what's important with those is that the first two questions you'll see there are some not applicable responses, and I would encourage you please to click not applicable if it's not applicable to you from your perspective as opposed to some other response. So if we can go to those poll questions, that would be great. And I'll read the poll questions. So the first one is, how likely are you to participate in a statewide networking focused on harm reduction services with similar organizations? So this is focused more on people who are service providers or partnering with service providers and or want to help partner with them around services that are harm reduction oriented. So if people would please fill out that poll.
Yes, Caleb, and the responses are very likely, somewhat likely, neutral, not likely, not applicable.
Thank you, Lisa. Okay. So the responses came back 60%, so they're very likely to do that, 25% somewhat likely, and smaller proportion sort of neutral or not likely, and about 7% so it's not applicable. So that's something we'll certainly be looking at going forward in terms of how we can support that. The next survey question, how likely are you to participate in a statewide networking focused on harm reduction education with other people with lived experience of drug use? So this is really for the 29% of folks who identified as people with lived experience and or that they would really want to partner and connect with other people with lived experience to think about education or advocacy issues. So the response options are very likely, somewhat likely, neutral, not likely, and not applicable. So if you would respond to that, please. Great, thank you for your responses. So 43% said very likely, 20% somewhat likely, and smaller proportion saying neutral and not likely, and thank you for indicating not applicable. My favorite response as a researcher for people to accurately document not applicable. So thank you for that. The next question. How likely are you to participate in regional interdisciplinary networking focused on harm reduction services and coordination with other local services? So with the regional level, kind of like the breakout groups that we're doing, but more sort of going forward and more action oriented about how to collaborate and partner to provide really a good continuum of services. The response options are very likely, somewhat likely, neutral, and not likely. So if you would complete that, don't worry, we're almost done with these. Okay, awesome. So the responses here, 60% saying very likely, 24% somewhat likely, 13% neutral, and 3% not likely. So again, it looks like most people are interested in that, which is heartening. Maybe that's why you're here, hopefully. So excited about that. And I can't remember if we had one more question or not. I thought we did. Great. Last one here. Let me explain this a little bit. How likely are you to participate in statewide best practices presentations and technical assistance on harm reduction approaches from community practitioners? So that's like what we just did with the housing panel. This is more kind of content driven or information sharing that may be a little bit more of a panel presentation with discussion. So how interested would you be in getting sort of ongoing education on best practices across a range of things related to harm reduction? We just talked about housing, talked about the counseling approaches, we could talk about overdose prevention, we could talk about a whole range of things that people are interested in, would certainly be taking people's input. So really, how likely are you to participate in best practice presentations and TA on harm reduction approaches? So the responses are very likely, somewhat likely, neutral, and not likely. So if you would submit that. Okay, again, there's a theme. Some very likely with 62%, 21% somewhat likely, 11% neutral, and 6% not likely. So it sounds like there's interest in a whole array of things, which is wonderful. And so we'll do some work here with our planning group to sort of take this information and think about what we can put out there. And we will definitely follow up with people about opportunities, and really, really appreciate people's active involvement and feedback in these polls and the chat and so on. And I'm going to now hand it over to my colleague Malika Lamont to talk about the next section. So thank you all, and talk with you in a bit.
Hello, everybody. In our next section, we're going to be moving into our regional breakout groups. And Lisa and I are going to let you know what that next step is going to look like. We're hoping that it'll provide an opportunity to learn more about who is living and working in your region, to build and strengthen partnerships and networks to better serve all of your community members, to fill the gaps and extend and share resources across your region and also throughout all the regions that are present in this conference, and then also to take concrete steps and create action steps within your regional breakout groups. The conversation will be facilitated. You will be receiving links to your breakout group, and you will be able to access the expertise that is in your community and hopefully get connected with people.
Yeah, Meg, can you go to the next slide, please? So in your breakouts, as Brad said at the beginning, we have 10 breakouts aligned with the ACH, BHO regions, and then one for American Indian, Alaska Native community members and providers. So we're hoping in today's breakout that you can do a recap of the breakout that you had on 6/22, June 22nd, any takeaways or action items from that. And then maybe some discussion about the models of housing and homeless supports and services that we heard from the panel, how connected you are to those homeless and housing support services, and what do you need to get more connected. I think we heard from everybody that housing and homeless services are a critical part of the whole continuum of care for people in our communities. And then again, identifying who else is not yet at the table and how you can connect with them. And then I think Malika wants to talk about this a little bit more, and Caleb talked about it too. Are there existing coalitions, efforts, groups already doing this work and serving people who use drugs in your region? And how can you connect with them, align with them, coordinate with them? I don't know if you want to say anything about that, Malika.
Just thinking about how in different communities, oftentimes we gravitate towards people that think like us, and so then but we also sometimes can have blind spots and we don't know how or where to connect with people. But we're engaging, for example, in an effort in Seattle and King County called Just Access for Health. And we are a cross-pollinated group of people, professionals, people with lived experience, recognizing none of those identities are mutually exclusive, activists, and we're looking to be a group that convenes all of these individuals to be able to collectively push for the priorities that we identify. And so we're hoping that maybe we can help to encourage each region to start thinking within that framework. It harkens to the Asset Building Coalition that we have in Thurston County, where we are a convener, and we recognize that asset building is not just about finances. Economic development is of course a part of that, but having access to, safe food and healthy food, housing, health, all of those different components are things in what we would all call probably the social determinants of health. And so we've taken that sort of lens with this Just Access for Health project up in Seattle. And so we're hoping that that will be the frame with which you're thinking about your region and who's not at the table, who do you think might not be an obvious partner, but you need to invite them into this conversation, and really thinking creatively about that as we're taking time today together.
Thank you, Malika. Nick, can you go to the next slide, please? So just like on June 22nd, here are the regions and the counties. We encourage you to join the regional breakout that is the community where you live and work, and or the one that you feel most comfortable in. And for state partners, please feel free to select the one that seems most relevant for you or exciting or interesting. Here's a map. Put the link in the chat box. That's a great idea. Nicole or Meg, can one of you please? Oh, there it goes. All right, so there's the link to join the breakouts is now in the chat box if you want to copy it and paste it into your browser. I want to thank everybody who has spent time with us this morning. I want to thank the planning group for working so hard, as Caleb said, over the past number of months to pull this together, and for quickly and nimbly switching from an in-person to virtual. Thank all of you for your patience while we work through virtual hiccups. And thank our panelists and facilitators for today. And especially thank Chairwoman Nelson for opening us in a good way.